This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. In case you knew, I'm a med-peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. Now, pardon me, we've been coming to you from this podcast since October of 2016, marching through the American Board of Pediatric Content Specifications for Pediatric Hospital Medicine. And you know, if you're listening to this, this is part of our special Journal Club series. Now, what this is a series of podcast episodes where we're covering the research section for the American Board of Pediatric Content Specifications for Pediatric Hospital Medicine. And we are doing this in conjunction with our partners in Austin, Texas, and Dr. Lynn Thorson. Thank you. And, of course, Dr. Philomena Lynn here, and all of our friends we have had that have been able to come on the show and be experts and walk us through these research topics. And today is no exception. We have a good one that I have always had trouble with, but we have the right person to help us with this. I'm going to introduce your expert guest, Ms. Rebekah Miller. Ms. Miller is a research and instruction librarian at the University of Pittsburgh's Health Sciences Library System. She received her master's in library and information sciences at the University of Pittsburgh and is an alum of the Critical Appraisal Institute for Librarians. She's a co-author on multiple systematic reviews and teaches classes at the University of Pittsburgh on critical appraisal. So, Rebekah, thank you so much for joining us. Welcome to this podcast again.
Thanks for having me.
Now we're going to call you friend of the podcast, Rebekah. You've been done this a couple of times. That's the title we give our people who've been here a few times. Let's do our conflict of interest statements first. We'll get that out of the way. I will go first. On a vaccine administration board at Sanofi, which should have no bearing on the topic we're talking about now.
All right, and I have no conflicts of interest to disclose.
So, Rebekah, I'm just going to kick it out to you broadly. What is bias, confounding? Why are we talking about this? Why does the American Board of Pediatrics think it's important for us to learn this?
Okay, so bias is actually just a systematic error in a study. So the reason that's important is because, when you're looking at a study, you want to think about, I'm looking at the results. Are the results going to be valid? Well, you have to know if there's potentially errors in the study, right? So the error could be in the design of the study. It could be in how it's conducted. Really, at any point in the study, something happened and then there was a systematic error introduced. So the thing about bias is you can't necessarily eliminate it, right? It's potentially going to be in a study no matter what. But people, when they're designing a study, they can mitigate it. So you can, when you're reading a study, you can say, okay, maybe there were biases, but were they mitigated? Did they do a good job of handling the bias as well as they could? And you also can't measure bias. So you can't say like, oh, this is like 5% biased, right? You can only assess the risk of bias. So you can say, well, there's a high risk of bias or a low risk of bias when I'm looking at the study, but you can't say like, oh, it's a certain amount of bias. So if you're thinking about, okay, well, how do I assess the risk? There are tools out there to help you with that. Cochrane has some tools for assessing risk, or you can just kind of try to be familiar with different types of bias and figure out, okay, what do I know to look for? What can I make sure is in a study or not in a study when I'm thinking about whether it's biased?
So if I understood you right, the simplest definition is bias is a systematic error in a study.
Yes.
And the bias, and in terms of the design of the study or how it's conducted, and we can't measure how much bias there is. You said no, not like 5%, just high or low. And I'm assuming there are ways to make those calculations, whether it's high or low, in terms of how much bias. Did I kind of summarize? Did I kind of repeat that correctly?
Yeah, I would say so. I mean, you can also have like a medium level, right? So it's really just you're looking at how much bias do you think was introduced in the study, and yeah, so that's you're not going to measure it, but you can say, okay, well, they mitigated it by doing X, Y, Z, and we can talk about some ways that people mitigate bias, but there's always potentially going to be bias in a study just because that's how it is, right? It's life when you're doing a study.
Yeah, that was going to be one of my questions. Is I think people we've discovered these past couple of years, all of us are inherently biased. Some people already knew this. So when you say mitigated, I'm assuming that you can't 100% eliminate all bias. You can just offset it as well as you possibly can. Is that a fair way to say it?
That's fair. And I think that our job when we read an article is to judge whether they did a good job mitigating the bias. So if you're reading an observational study, that's just inherently going to be more prone to bias because there's less control, right? In an experiment where you're putting people in groups, you're going to have more control and you can mitigate the bias a little bit better than in an observational study when you're just watching people and they might just do what they do, right? So if you're thinking about an observational study, you want to see that they did some careful planning, that they did something like they made sure their measurements were really precise. So if they were interviewing people, did they use a template to make sure everyone is asking the same questions if you have more than one person asking questions? So those are the kinds of things that you can look at. So the design needs to be really precise. Did they report what they did? Did they use protocols? Things like that are ways that you can make sure an observational study mitigated the bias to the best that it could.
So an experimental study, you're saying, can mitigate bias by thinking about where bias could be and then setting up the study to minimize that as much as possible by like standardizing questions. But you're saying an observational study, you're just observing what already happened. So I'm trying to understand, if there's bias in those systems, you're just observing the systems, so there could be bias?
Sorry, no. What I was saying was that those are ways to mitigate bias in an observational study. So if you have an observational study, you can try to mitigate bias by doing things like making sure you're doing this careful planning, using these interview templates. So those, because you have less control over what people might be doing, you can control the way your study is designed. Does that make sense?
Okay. Yeah, so when you said observational study, I immediately thought of all these retrospective phys database studies where you don't really interview anybody, right? You're simply looking at the database and pulling that stuff out. You're talking about observational studies where you may interview people, have to talk to people.
Well, so if you're thinking about ones where you're just looking at something that was in the past, maybe you can make sure that, let's say you're looking at heart rate. So how was heart rate measured, right? You want to make sure it was measured the same way for each patient. Or if not, you're going to say, okay, that's a bias that was introduced. That might be some sort of measurement bias. So we need to at least talk about that in the limitations part of our paper, right? We need to acknowledge that that was a potential bias that was introduced.
Okay.
Does that make sense?
Okay. That makes sense. So in these observational studies, using the retrospective chart review as an example as a type of study, you want to make sure the measurements and what people are, whatever you're looking at is the same throughout all the patients. Otherwise, there could be measurement bias.
Right. And sometimes there's just going to be measurement bias, and that's okay. And you just have to, say, okay, well, what impact does that have on my outcome? You just need to deal with that as the researcher and as the person reading the study. You just want to make sure it's clear. Where did they get the information? How are they accounting for anything that might be different if there's a chart from one hospital versus another hospital?
Interesting. And then for experimental studies, if you're designing something, how would you help us? How would you go about bias?
So probably the biggest thing that you can do is randomization. So if you are randomizing your two groups, that's making sure that, all the healthiest people aren't in the intervention, right? Because your intervention is going to look really good if everyone was already healthy in that group. So randomization is going to disperse the different types of, complications that you could have. So that's going to help reduce your bias. Masking or blinding, that is going to help reduce bias, because if people don't know what treatment, or if they're getting a placebo or a treatment, then they're not going to act differently, right? Because they don't know. So that helps to reduce bias. And then making sure that if you can, having the actual study, the people doing the study being blinded as well helps. Again, it's not going to introduce a bias if you don't know the person in front of you, if they're on the placebo or the treatment. Another thing you want to think about is concealed allocation. So the blinding happens after you've already been put in a group. So if you've been put in a group and you don't know which group you're in. But concealed allocation is when You don't know how people are even being put in groups, right? So it's concealed how the allocation process is working. So again, you're not going to accidentally put all the healthiest people in one group because you figured out the way that the groups are being allocated, right? And I say accidentally because, you might not realize you're introducing bias because you're just saying, oh, this person will do well in this group, not thinking that it's going to bias your study.
Okay, that makes sense. Randomization, allocation. Okay. And then are there types of bias that we can think about?
Sure. So there's actually an intense number of biases that we could think about. So we're not going to talk about all those today, but I do encourage people, if they're interested, to take a look at the Catalog of Bias, which is actually just catalogofbias.org. And that comes from the Center for Evidence-Based Medicine in Oxford. So they're putting together a catalog of all the different types of bias. And it's really interesting because it gives you a definition and then an example. So if you're like, oh, I'm not really sure what this is, you can take a look and say like, oh, okay, I've seen this in studies. I understand this bias. So that's something for people to look at. But just some biases that I think are, fairly important to make sure you're looking at. The first I would say would be selection bias. So selection bias is when the two groups being studied are systematically different. Right. So if we're looking at maybe like table 1, it's not always table 1, but it's often table 1 where you're looking at the populations in a study, right? They'll compare them side by side. And that's where you can see like, oh, this population seems like this group was way healthier than this group. And I can tell because of, whatever the parameters are,
yeah.
Right? Or like this group had a lot of smokers and this group didn't. Did that impact the study? So
can I ask an example like this? A simple one would be, if I wanted to judge how many push-ups the average high school student could do, but I only went to the wrestling team, then I would clearly get a bias. They do push-ups all the time. That's a selection bias. That number should be higher, we would think, than the average high school student who's not on the wrestling.
Exactly. So that's the second sort of type of selection bias where the people recruited for a study are systematically different than the rest of the population, right? The wrestling team is going to be fitter. They're going to be better at push-ups than maybe the rest of the high schoolers or whatever, school you're in. So that you want to look at the recruitment methods. So if you just went to the wrestling team, well, that's not really going to be that generalizable of a study.
Okay. Selection bias. That makes sense. And this is something we have in pediatrics have gotten a lot of publicity about, well, medicine in general, because of we are trying to select more diversity in our patient populations that we do studies so it adequately represents the country itself and not just a specific subset of the country.
Exactly.
Okay.
So that's really important.
Sounds great. All right.
So another bias you might want to think about is recall bias. And so this is also when we were thinking about observational studies that are actually interview people rather than maybe this could be part of a chart review too. But basically recall bias is that when you're asking someone about the past, are they going to accurately remember? Right. So a lot of we do food and nutrition studies, they'll say what did you eat for dinner last week? And it's I have no idea. Right. But the problem too is that if you're asking, let's say you're doing a case control study and you're asking people who have a specific disease about something that happened to them in the past, maybe an exposure, and you're asking people without disease about an exposure, the people with the disease might be more likely to remember because they're thinking, well, what happened to me in the past? Why was I exposed to something? Why did I get this? So they're going to remember a little bit better than people who are just kind of, going on their way. So that's going to be something systematically different between the two groups, right?
The one group will be dwelling on it because they got the condition. Mm-hmm. And naturally humans think, what happened to me to get this? Whereas the well group won't be thinking about anything.
Yeah, exactly. Okay. Right. So that can introduce a bias too, right? So they're going to be systematically different. And then also, is it even an accurate answer, right? So to mitigate that, it's a little bit more challenging, but you could try to independently confirm answers, which again, how can you independently confirm whether someone ate something specific? But it could be, did you actually interact with some sort of toxin or something like that? You might be able to confirm that. And you can also say to people, not say to people what the focus of a study is. So if they don't know what the focus is, they might be you might get a better answer because they're not trying to hear their answer to be helpful.
Okay. That sounds like it's a harder form of bias in observational studies to combat against, because you're inherently going to need some recall for a lot of different types of observational studies. And that's one of the ones you have to live with, but do your best to mitigate.
Exactly. And just because you see recall bias in a study, it doesn't mean you should throw the study out, right? It's just something to consider when you're reading it.
Okay, that's good to know. All right. What else you got?
All right, so I think that another one, let's talk about attrition bias. So attrition bias is when people drop out of a study. So that's always going to impact the results, right? And people are usually going to drop out of a study. It's just kind of a natural thing that happens. So what you want to look at if you're reading a study and people dropped out, you want to say, okay, well, did more people leave from one group than another? Because maybe there's something going on with the intervention. Maybe it was a drug and it was harsh side effects and people dropped out. Or maybe it was some kind of diet that people didn't want to stay on, something like that. Or is there something systematically different about all of the people who left? So maybe an even number from both groups left, but the people who left were all sicker, or there was something about them fundamentally, systematically different than the people that stayed. So what you want to see in a paper is you want to see that the researchers accounted for why people left. So they say these 5 people left the study and this is why they left. And they're not always going to know, but sometimes they can reach out and find out. So if you're looking at a randomized control trial, the most important thing you want to look for is what's called an intention to treat analysis. So basically what this is when someone is randomized into a group, they are analyzed in that group no matter what. So basically, if you are in the control group, you're analyzed in the control group no matter what, even if they give you the intervention for whatever reason or you drop out, no matter what, you want to see that they were analyzed the way that they were originally put. And that's because that preserves your randomization.
Okay. So to preserve randomization, even if people drop out, you want to see the intention to treat?
Right. So when you look at that, a lot of times they'll have a chart and it'll be like, oh, this is as many people screened. This is as many people that were included in the study. Here, this many were randomized. Let's say 20 went to the experimental group and 23 went to the control. You want to see, sometimes you'll see, okay, then through the 23 that got the control, then you see they only analyzed 20 because 3 dropped out. You want to see they analyzed 23. So you want the numbers randomized to be the same at the bottom of that chart.
And the reason for that is because it maintains your randomization. Otherwise, you could have a bias from people dropping out, but then it could end up leading to a selection bias. Is that correct?
Right.
So one bias can lead to another, and you mitigate that by keeping them in the randomization and the calculation.
Right. So if you see that someone says that they did a per protocol analysis, that means they analyzed people based on what actually happened with them as opposed to how they were randomized.
Okay, so the per protocol is the opposite of what we're talking about. The per protocol is if they dropped out because of whatever reason, then they're out in the calculation. So per protocol, whatever happens. Intention to treat, they are in those calculations no matter if they drop out, leave the country, or whatever it is they do.
Exactly.
Okay.
So we want to preserve that randomization again to try to get rid of some of that bias.
That's okay. All right. Now, what about how do you measure this? We talked about low bias or high bias. We've talked about mitigating, and we've talked about some types of bias, but how do you measure bias?
So again, you can't measure the bias itself. So you're measuring the risk of bias. So how much, is there a high risk of this study being biased? So I think that if you're actually systematically doing it, let's say you're doing a systematic review and you're trying to analyze it, I would recommend going to Cochrane. They have some tools. They have a risk of bias tool. So I would work through that. If you're not doing something as systematic as that, what you could do is you could just pull up something like the bias catalog, or you could look at something like there are critical appraisal tools. So like CASP, CASP, they have tools that help you work through a study. So that's not going to necessarily tell you how high a risk of bias at the end, but it will work through, okay, here's where the study is working for me, and here's where the study, maybe there are some issues with it.
Okay, so there are tools we can use if we're looking at a study, and I guess then really us reading the study and what their methods were, would perk up our antenna to say there may be risk of bias here,
Exactly.
and we could then go to any one of these tools to do some and they'll give us a number or a high or low risk of bias. Is that what they'll say?
They won't give us a number, but they'll say if you're using something like Cochrane, it will guide you through a decision, whether it's a high, a low, or a medium risk of bias.
Okay. And is this what people who do meta-analyses or systematic reviews do? Mm-hmm. When they take each individual study, they should look at them for bias?
Yeah. So depending on, there are a lot of things that go into it, but when you're doing a systematic review, there are lots of different tools that people use. But that is one of the things you want to do, especially depending on what kind of a study you're looking at. If the systematic review is looking at RCT, yes, you want them to assess the risk of bias somehow. And you want them to tell you how they did it.
Okay. So an interesting example in pediatric hospital medicine a few years ago, those people who've been doing this a while will remember this, 3% sodium chloride nebulized, a Cochrane review came out saying that it's beneficial for bronchiolitis. It'll lower the length of stay by, I think, half a day. And then almost immediately thereafter, a systematic review came out saying that 2 or 3 of the studies used in the Cochrane review had bias because they were in China, and there they would use the medication at any point during the bronchiolitis, when the patient had bronchiolitis, and they were using it during the end, which with bronchiolitis, by 4 or 5 or 6 days in, it's already wrapping up by itself. It's a viral induced condition. So they felt those studies introduced bias. When they took them out, and I forget the tool they used, there was no difference. There was no help with 3% sodium chloride nebulized in bronchiolitis. So that's an example of how using these tools can help really change a systematic review's results completely.
Right, because that's a great example. If you're doing a systematic review and you might say, well, all of the studies we found had a high risk of bias, so we can't really draw any conclusions because they're too flawed for me to draw a conclusion. So I can't say whether something works or doesn't work.
All right. So now, confound. Yes. I'm confounded by confound.
All right.
You had to know I was going to say it.
Yeah, that's still a good one. So confounding is a type of bias. But basically what it is when there are additional variables impacting an outcome. So you can't tell if the effects or the outcome that you're getting is because of a confounder or if it's from the variable or exposure or whatever it is that you're studying. Right? So it's something else floating out there that may be causing the outcomes. So for example, in 2020, there was a study that came out about baldness and COVID, and it said that people who were bald were more likely to get severe COVID. So there was a confounder that they weren't accounting for, and that was age. So they were saying it was just like not having hair was causing severe COVID, but they were forgetting that age is a gigantic confounder, right? So there's something else floating out there that they weren't accounting for in their study that was potentially causing what they were saying that their variable was causing.
That's a great example. When so the baldness, older people are bald, and the older people were more affected by COVID. Oh, that makes okay. So an additional variable affecting the outcome that you can't account for at this point.
Right.
So if I'm creating a study and I think I have a direct correlation, how can I, or if I'm reading a study, I'm like, oh, this makes sense. X, Y, Z, X causes Y causes Z. How do I think of, or how do I take into consideration confounding?
So you want to look for, if you're looking at a study, you want to look for differences between comparison groups. Again, same thing as before. So again, you want to see that they randomized, because randomization helps balance possible confounders, right? So if you have a randomized, you'll have, these, various ages in both groups, right? Or, some people will be bald because they shave their head and some people because they're older, right? In both groups. So you want to see randomization. That's the only way to deal with unknown confounders. So something that you're like, I had never thought of that. I wouldn't know that would be a confounder. But if you're looking at known confounders, so you're doing a study or you're reading a study and you're saying, well, I know that this something is a confounder. What researchers can do is they could use restriction, meaning like, okay, I know that in my population, smoking is a confounder, so I'm going to have a study with no smokers. But again, that's going to introduce some selection bias, right? Because maybe it doesn't match your population. The other thing that you could do is you can do some statistics. So you see a lot of times people use multivariate analysis. So that is a way to deal with confounders. Or you'll see stratification. So that's another way to look at it and try to handle confounders.
And those are a way to try to pull out the confounders and try to see what the data shows.
And again, those are known confounders, but yes, exactly.
Right. So in our previous example of the studies in China on 3% sodium chloride nebulized in bronchiolitis, they took those treatments as effective. And to us, that's a confounder because the bronchiolitis will wrap up on its own on day 5, 6, 7, let's say.
Right.
So it was likely the disease had run its course and the 3% sodium chloride nebulized was neither here nor there. So that was the confounder, just time.
Right. Exactly.
Oh, that's fascinating. Okay.
So the other thing to know about a confounder is the confounder has to be independently related to the outcome. So it can't be part of the causal pathway. And so I don't know if this is a good example, but this is what I could think of this morning. So if you are, let's say you're saying you want to check whether fermented foods help improve immune response. So if you give someone fermented foods and then you see that their gut bacteria improves, or they have good gut bacteria or something, the gut bacteria is part of that pathway. So that is not a confounder.
Okay, so the gut, if you want to give someone fermented food, so to do that study, you would probably measure their gut bacteria before in their stool and measure it after. And you're actually measuring the gut bacteria. Right. So that can't be a confounder.
Right. So if it's part of the pathway of what's happening, it's not a confounder. It has to be independent.
So in our baldness example, being bald has nothing to do with COVID or respiratory distress or viruses or anything. That's why it can be a confounder. That's why age can be a confounder. Because it's not involved. You don't get COVID because you're older. You get COVID because it's spread like a virus. Right. Okay. And then time for our bronchiolitis example, that has nothing to do with the virus and the pathophysiology of the virus and the immune response. That's just what happens. It goes away after time.
Exactly.
Okay. But so then something directly related to what we're studying, can't be a confounder. Right. That makes sense.
It's just something independent that we may or may not have thought of and that is going to, potentially impact the outcomes.
That's interesting. Okay. So, all right. I can't think of another example. I was trying to think of with our wrestling team push-up example, something simple, but I can't be sure. The bias is the fact that they do push-ups all the time. That can't be a confounder. Maybe on the wrestling team is part of a bias and confounding because then I don't know, maybe we're pushing.
I'm trying to think I'm sure we could think of it if we sat here for a few minutes.
But I think the other two, the bald example and the actual studies on 3% sodium chloride nebulized are good examples. This was very helpful. I think I learned a lot here. Thank you.
Yeah, thanks for having me.
Did we cover everything you wanted to cover, Rebekah, for this topic?
I think so. I guess what I would say is when you're reading a study, the most important thing is to be able to tell what they did. So sometimes you're reading and you can't even tell. So that not being able to tell what they did isn't necessarily a sign that they did a bad job. But if you can't tell what they did, then you can't analyze whether they did a good job or not. So I think that it's really important that when we're reading articles that we can understand what everyone, with how they did the study, but also if any of your listeners are writing articles, just being clear about their methods is really important.
That is great advice. Just absolutely great advice. Rebekah, thank you so much for your time. I really appreciate it.
Well, thank you for having me.
Oh, it was my pleasure. And I'm sure we're going to see you again for more of these episodes. So we'll see you soon.
All right. Sounds great.
Thank you for joining us for this Journal Club series at PHM from Pittsburgh. We want to especially thank our expert guests for their time.
Special thanks to the University of Pittsburgh for sponsoring the CME for this podcast, and UPMC Children's Hospital of Pittsburgh for supporting this podcast as well. We want to thank our friends at Dell Children's Medical Center and the University of Texas at Austin for their partnership on this endeavor.
Please email my dad at tony.tarchichi@chp.edu with any questions or comments. And as always, thank you for listening!